Endocarditis is an cardiovascular disease condition. Look at this picture, shows that endocardium. Echocardiography findings. Look at this. Then ECG findings and chest X-ray. Look at this. A detail going on. Introduction. Endocarditis is a serious medical condition characterized by inflammation of the inner lining of the heart, particularly the endocardium and heart valves. It is usually caused by an infection. Often bacterial, but can also be due to fungal or other microbial agents. Despite being rare, it can lead to severe complications if not diagnosed and treated promptly. Definition: endocarditis is defined as the inflammation of the endocardial layer of the heart, most often involving heart valves, due to microbial infection. The infectious agents adhere to the damaged heart lining or parasitic material and form vegetations, masses of platelets, fibrin, microorganisms, and inflammatory cells. Etymology: the term endocarditis comes from the Greek word endon meaning within, cardia meaning heart, and the suffix itis meaning inflammation. Thus, endocarditis literally means inflammation of the inner layer of the heart. Epidemiology: endocarditis is a relatively rare but serious condition within a estimated incidence of 3 to 10 cases per 100,000 people per year. In developed countries, it is more common in males with a male to female ratio of approximately 2:1 and predominantly affects older adults over 60 years, especially those with pre-existing heart conditions, prosthetic values, or a history of intravenous drug use. The incidence has increased slightly due to aging populations, increased use of cardiac devices, and higher survival rate among at risk Groups. Types. A. Infective endocarditis. 1. Acute infective endocarditis, rapid progression, usually caused by virulent organisms like Staphylococcus aureus. 2. Subacute IE, slower onset, often caused by less virulent organisms like Streptococcus viridans. B. Non-infective endocarditis. 1. Melanotic non-bacterial thrombotic endocarditis associated with malignancy or hypercoagulable state. 2. Lippmann Sachs endocarditis associated with autoimmune diseases like systemic lupus erythematosus, SLE. Causes. 1. Bacterial infection, most common Staphylococcus aureus, Staphylococcus viridans, Enterococci. 2. Fungal infection, Candida species, especially in immunocompromised individuals. 3. Intravenous drug use. 4. Dental procedures causing bacteremia. 5. Invasive procedures, example catheter insertion. 6. Heart valve surgery or prosthetic valves. Risk factors. 1. Congenital heart defects. 2. Artificial heart valves. 3. Rheumatic heart disease. 4. Previous history of endocarditis. 5. Intravenous drug use. 6. Poor dental hygiene. 7. Immunosuppression, example HIV, chemotherapy. 8. Long-term use of central venous catheters. Complications. 1. Heart failure. 2. Valvular damage or insufficiency. 3. Embolic events, example stroke, pulmonary embolism. 4. Mycotic aneurysms. 5. Septicemia. 6. Kidney failure. 7. Abscess formation in heart tissues. 8. Death if untreated. Pathophysiology. The pathophysiology of endocarditis involves a cascade of events leading to the infection and inflammation of the heart's inner lining and walls. Below is step by step breakdown. Step 1, endothelial injury. Damage occurs to the endocardial surface, particularly heart walls, due to turbulent blood flow, example congenital defects, prosthetic valves, rheumatic heart disease. This damage exposes subendothelial collagen, making the site more prone to thrombus formation. Step 2, platelet and fibrin deposition. A sterile thrombus form at the site of injury. This is called non-bacterial thrombotic endocarditis and consists of platelets and fibrin. Step 3, transient bacteremia. Microorganisms, mostly bacteria, enter the bloodstream from the source like dental procedures, skin infections, IV, drug use, catheter or invasive devices. These organisms circulate in the blood bacteremia. Step 4, microbial adherence. Circulating bacteria adhere to the platelet fibrin thrombus on the damaged endocardium. Microorganisms use surface adhesines to attach and resist host immune defenses. Step 5, vegetation formation. Bacteria multiply and are embedded in the protective matrix of fibrin and platelets, forming infective vegetations. These vegetations enlarge and can damage wall tissue, sealed fragments, emboli. Step 6, local tissue destruction. Microbial toxins and immune responses cause destruction of wall tissue, leading to wall insufficiency, abscess formation, perforation or rupture of heart structures. Step 7, systemic effects and embolization. Fragments of vegetations can break off and travel through the bloodstream, causing stroke in brain, pulmonary embolism in lungs, renal infarcts in kidney, splenic infarction. Ongoing infection can lead to sepsis and multi-organ dysfunction. The pathophysiological process explain the clinical features of endocarditis. such as fever, murmur, embolic events, and valvular dysfunction. Early diagnosis and treatment are essential to interrupt the cascade and prevent complications. Signs and symptoms: 1. Fever and chillness. 2. New or changing heart murmur. 3. Fatigue or weakness. 4. Night sweats. 5. Fatigue, tinny red, purple spots on the skin. 6. Genivaliscence, painless spots on palms, soles. 7. Muscular nodes, painful red nodules on fingers, toes. 8. Root spots, retinal hemorrhages with white centers. 9. Splenomegaly. 10. Arthralgia and myalgia. 11. Shortness of breath and chest pain. Diagnosis: 1. History and physical examination. 2. Blood culture, multiple sets to identify organism. 3. Echocardiography. A. Transthoracic TTE. B. Transesophageal TEE, more sensitive. 4. Modified drug criteria, clinical, microbiological, and echocardiographic findings. 5. CBC may show leukocytosis or anemia. 6. ESR and CRP elevated. 7. Urine analysis may show hematuria or proteinuria. 8. Chest X-ray and ECG assess complications. Nursing diagnosis: 1. Risk for ineffective tissue perfusion related to embolization. 2. Risk for infection related to microbial inversion. 3. Fatigue related to systemic infection. 4. Acute pain related to inflammation. 5. Anxiety related to illness and hospitalization. 6. Deficient knowledge regarding disease process and treatment. Medical management: 1. Antibiotic therapy, broad spectrum initially, then organism specific IV antibiotics for 4 to 6 weeks. 2. Antifungal therapy if fungal origin. 3. Surgical intervention, valvular repair replacement for damaged valves or uncontrolled infection. 4. Antipyretics and analgesics. 5. Management of complications, example heart failure. Nursing management: 1. Monitor vital signs, especially temperature and heart sound. 2. Administer antibiotics as prescribed. 3. Monitor for embolic events, stroke, signs, hematuria, chest pain. 4. Provide rest and conserve energy. 5. Maintain aseptic techniques during invasive procedures. 6. Educate the patient on completing antibiotics and signs of relapse. 7. Promote oral hygiene to prevent recurrent infections. Treatment options. 1. Empirical. 4. Antibiotics, example vancomycin plus ceftriaxone. 2. Targeted IV antibiotics based on culture. 3. Surgical wall repair or replacement. 4. Antipyretics for fever management. 5. Anticoagulation. Controversial, usually avoided unless another indications exist. 6. Management of heart failure if present. Example diuretics, inotropes. Psychosocial medicine. 1. Emotional support help patients cope with fever, anxiety and uncertainty. 2. Education and counseling about the illness, treatment and lifestyle changes. 3. Support groups connecting with others who have experienced endocarditis. 4. Substance abuse counseling, especially for IV drug users to prevent recurrence. 5. Rehabilitation planning for patients recovering from surgery or embolic events. Prevention. 1. Prophylactic antibiotics before dental or surgical procedures in high risk individuals. 2. Good oral hygiene. 3. Avoidance of IV drug use. 4. Sterile technique for catheters or invasive procedures. 5. Early treatment of infections. 6. Regular follow-ups for patients with heart defects or prosthetic valves. In conclusion, endocarditis is a potentially life-threatening condition, particularly caused by microbial infection of the heart inner lining. Early diagnosis, prompt antibiotic therapy when necessary. Surgical interventions are critical for successful outcomes. Patient education and preventive strategies play vital roles in reducing recurrence and complications. Multidisciplinary management, including psychosocial support, is essential for optimal recovery and long term health. Thank you. Have a nice day.